All right, good morning. This is our lecture on myelograms. So myelograms are the radiographic study of the spinal cord and its nerve roots. Contrast media is injected into subarachnoid space in the study. So today we'll be talking about the two different types of contrasts. We're going to use the water-soluble non-ionic iodinated contrast, and we're also going to use gadolinium. So the water-soluble contrast is used for CT and regular arthrograms, and myelograms will be used with gadolinium if we're going to do an MRI. Clinical indications. So the reason why we're doing a myelogram is for the presence of lesions within the spinal canal or a lesion that could protrude into the canal. When we inject contrast, the spinal cord and nerve roots are outlined by the contrast. We see pathology based on how the contrast shapes this area. Procedures can take 30 minutes to an hour. It also adds, you also need to add time in for CTs if they're ordered. So the myelogram will only take 30 minutes, but then the CT may take an additional 30 minutes. So just make sure you let the patient know. Usually when patients schedule these exams, they're usually there for about 2 hours. They have to get there, make sure that all the consents are signed, go through everything, get dressed before the procedure. So that takes about 30 minutes, and then the procedure for the myelogram takes 30 minutes, and then the CT takes an additional 30 minutes. And that's if everything is running smoothly, but usually another CT is always being done while you're waiting, or like patients show up late. Sometimes their appointment's at 10 o'clock and they show up at 10 o'clock where they were supposed to show up at 9:30 to make sure that they register and change. So let's take a break real quick and talk about radiation protection. We're going to talk about our badges again, our dosimeters. So the ones again we wear are the optically stimulated luminescence OSL dosimeters. Provides best features of traditional film badges, and TLDs are thermoluminescent dosimeters while eliminating disadvantages. So this is the ones that most people will wear. It's the most common type of device used in imaging. It contains, and this is important to remember, aluminum oxide, ALO detectors. So they do like to ask these questions on the registries. The readout is used by a laser light. So again, it's optically stimulated luminescence. So laser light, when laser light hits the badge, it becomes luminescent in proportion to the amount of radiation received. So the laser hits it. If you received a lot of radiation, it's going to become super, super bright. All right, back to myelograms. So symptoms. Some symptoms that may manifest in the patient that would require a myelogram are just basically pain and numbness. Contraindications of a myelogram. Blood in the CSF, blood in the cerebral spinal fluid. Arachnoiditis, inflammation of the arachnoid member. Contrast can increase severity. Increased intracranial pressure, equalization complications between areas of brain and spinal cord. Recent lumbar puncture, 2 weeks prior to procedure, can cause extravasation of contrast outside subarachnoid space. Common procedure sites. So here we have our brain, a spinal cord. Right over here, the cord ends right here around L1. So the lumbar puncture site L3, L4 is like the most common area right here. So potential site for injection processes, lumbar L3, L4 is preferred site. Sometimes C1, C2, this is kind of rare. It's mostly the lumbar at L3 and L4. The reason why is because the lumbar area is a lot larger. C-spine is a very, very, very tiny space, so we try not to use this one. Sometimes if someone's having neck pain, they'll do the injection down here at the lumbar, and then they'll just make the table go like Trendelenburg, so it'll be kind of upside down, so where the contrast will flow from here all the way up to the C-spine area. Common puncture sites continued. The lumbar is the safest area. L3, L4 is below the end of the spinal cord and is the safest and easiest option for the patient. Remember, the spinal cord pretty much ends at L1. Cervical puncture is done only if lumbar area is contraindicated by pathologic blockage above lumbar area. Common pathologies seen. You'll go more into pathologies next semester, but for now, HNP, herniated nucleus pulposus, slip disc, very, very common. I actually have, the last time I had my MRI done, I have 3 herniated discs in my neck, 2 in my thoracic area, and 3 in my lumbar areas. So very, very common, especially with, doing x-ray on heavy patients for 15 years. Cancer, tumor, cyst, again, these are different pathologies that you're going to see in myelograms. Bone fragments. So as people are more hunched over, they tend to break the anterior portions of their lumbar vertebrae. A patient position, they're laying in the prone position. They'll usually put like a pillow here. So this will kind of straighten out the back. So if the back is completely flat, the needle will go in just like so. Patient prep. Muscle relaxant or sedative can be prescribed 1 hour before exam for anxious patients. It's a pretty large needle, and they're already scared because they're not sure what's wrong with their back, and then they know that there's going to be a needle. They probably watched YouTube videos on how the procedure is going to be, so definitely have some anxiety. Supplies, just like the same type of setup that we've seen for arthrogram and for the HSGs. Sterile gloves, you guys got to practice that a little bit with like the open and closed techniques. And most of the time you're going to be doing the open technique, not the closed technique. All right, so these are the supplies that are needed, just the needles, syringes, tubes for the CSF, gauze, sterile drape for the patient, betadine usually. So usually a myelogram tray is used to have the pertinent materials within the tray. This tray is sterilized and is prepackaged. So make sure you have your sterile gloves, know what size you are, antiseptic solution betadine, which is like right over here. Lab requisition, of course, to send the CSF fluid to the lab. Sponge or pillow to put underneath their stomach, and then a grid holder for cross-table laterals. Imaging equipment, you'll need a fluoro table equipped for a capability to tilt. So Fowler's or Trendelenburg table will need to tilt Trendelenburg. So here we have shoulder harnesses here. The head goes here. Shoulders will be stopped by these little breakers right here. Their feet will go here, and then there's even straps to hold the ankle. So when you put the patient in Trendelenburg in this position like this, these shoulder straps will keep them from falling off of the table, and their legs are secured by the ankle straps as well. So again, shoulder braces are right here, footrest with ankle restraints right over here. Again, somewhat type of a sterile procedure, so even the monitor is covered with sterile, like a bonnet or sterile drape. Contrast media for CT myelogram. So we can do myelograms with CT or with MRIs. Water-soluble iodinated-based contrast, easily reabsorbed. Important to use contrast cleared for intrathecal use. So intrathecal means in the spinal canal. So it's not oral, it says intrathecal. So the bottle, the contrast will actually say for intrathecal use only or not for intrathecal use. Approximately 10 to 15 mLs or cc's of contrast is used. Care to ensure contrast doesn't enter the head is important. If examining the cervical area, hyperextension of the chin may be advised when patients are in Trendelenburg position. So hyperextension of the neck is done like so. The head is kind of pointing up. It basically blocks the contrast from flowing into the brain. Because if what happens if you're probably going to ask, and they get severe headaches. All right, now we talk about contrast medium for myelogram MRIs. So it's basically the exact same procedure, except that we're using gadolinium in this case. So gadolinium is a different type of contrast used specifically just for MRI. It's easily reabsorbed. Again, important to use contrast cleared for intrathecal use. Approximately 10 to 15 mLs or cc's of contrast is used. Make sure the contrast doesn't enter the head by hyperextending the chin. Procedure. The procedure begins with a lumbar puncture. The lumbar site is cleansed and a local anesthetic is applied. Again, lumbar puncture needle is inserted around the area of L3, L4. They may use a different site, maybe L4, L5, maybe L5, S1, maybe L2, L3, but generally it's at L3, L4. Radiologists may use fluoro to help place the needle. The needle is slowly advanced until spinal fluid flows from the lumen of the needle after withdrawal of the stiletto. So the needle goes into the back, and then just like how you had the flashback from the venipuncture exercise, the CSF comes out exactly the same way. The stylet is returned, and the needle advances an additional 2 mm to ensure that the entire bevel of the needle is within the subarachnoid space. The small amount of spinal fluid is withdrawn to maintain stasis and to provide a sample. Contrast medium is injected under fluoro guidance. After injection of contrast media, the needle is removed and images are taken. So here we have all of examples of cerebrospinal fluid here. If it's cloudy like this, we're going to send it to the lab. If it's clear, probably don't need to send it out. All right, the procedure. Patient may be tilted into Trendelenburg to facilitate flow of contrast to area of interest. So again, patient is prone on their back. They probably have like a little pillow resting right over here. The X-ray tech will be here at the shoulders to make sure when the table tilts that they don't slide off of the table. Radiologist is right here. So once the area of interest, an AP or PA or both obliques and generally a lateral is taken of the spine. Before overhead imaging, the patient is tilted slightly toward the feet to allow pooling of the contrast material in the subarachnoid space below L1. So in that case, it'll be tilted a little bit to like a Fowler's position. Again, I believe this is just a general demonstration. If this was a real lumbar puncture, this would have like a sterile drape on it, and the radiologist would have his sterile gloves on if he's about to do this procedure. Quick video on myelograms. Just 2 minutes. All right, again for positioning, again, this would be like a Fowler's position here if they tilted it towards the feet. So it would pull by L1 or L5, L1 if you needed to. And this is how the contrast would look in the spinal canal. Again, this is your AP, your PA, and then this is your oblique right here. Looks like an LPO position. Left marker here. Scotty Dog's facing towards the left side. Cervical, cross table lateral. Patient is positioned prone with the arms extended along the sides of the body and the shoulders depressed just like so. The chin is extended or hyperextended and is resting on a small positioning sponge or folded linen. CR is directed to the level of C4, C5. The field should be collimated to reduce scatter radiation. So make sure you know the differences when we're doing lumbar. That would be like L3, L4. And then the C-spine is the level of C4, C5. Respiration is suspended during the exposure. Lumbar crest, cross table lateral. So L3, L4 are basically at the level of the crest. Patient in position prone again, arms extended above the head this time. The chin is extended and resting on a small position sponge or folded. So chin is still like hyperextended, but the arms, instead of being at the down position, they're in the up position. So we can do our cross table this way. The field should be collimated to reduce scatter radiation. Respiration is suspended during the exposure. So at the level of the crest, so you can kind of see where the crests are right here. And again, L5, L4. So if you're between L3, L4, then you're okay there too. Again, it's a right lateral. So right markers on the board, closest to the image receptor. Evaluation criteria. The approximate level of spinal column with contrast medium present should be demonstrated so we can see that the contrast is right here in the spinal canal. Left side is closest to the board, so cross table with the left side there. Correct exposure factors and adequate penetration helps to demonstrate anatomy and contrast medium. Patient identification markers and anatomic markers right or left should be clearly visualized without superimposing the anatomy. So make sure the marker is not here in the spinous processes or right in the lumbar area. We need to see if there's like an HMP, the herniated nucleus pulposus, if it's kind of leaking out. Collimation should be evident. So just collimate to the body. You don't need to have too much light above the free space here. You don't need the entire stomach. You just need the spinal canal and the vertebra. Post myelogram CT. So after the myelogram is done, we're going to take them over to the CT. In most cases, after myelogram procedure is completed, the patient is sent to CT. Imaging is seen in an axial plane, as demonstrated here at the bottom, transverse, so you can see the inside of the body. So this is more of like a sagittal cut here. You can see like a lateral. So you can do slices this way, or you can do slices. This would be the axial slices right here. There would be like the little H&P right here, where it's kind of leaking out. Again, just different cross-table laterals as pictured here. So they're centered at the crest, shooting across. Again, right side is closest to the image receptor, and you can see where this spinal needle is coming in. So it looks like this is L5, L4, L3, L2. So in this case, it looks like they put the needle between L2, L3. Again, collimation could have been a little bit better for this image here. It looks like they kind of burnt it out here on the top as well. So a little bit overexposed here, and they could have collimated down. But here you can see without the contrast, and then here is with the contrast. All right, again, spinal needles coming in here, and you can see the contrast coming into the spinal canal. Here they have a surgical fusion right here. Again, if you look here, this is L5, L4, and L3. So between L3 and L4 is where they're injecting the contrast into. Here's an example of a C-spine. Again, the head is kind of hyperflexed up a little bit, so the head is on a sponge. And you can see the contrast in here. We don't want the contrast to go into the head. So here the head is a little bit kind of flexed and not hyperextended. So the contrast is actually flowing up into the skull. Okay, we wanted to keep it to where you see the base of the skull, the occipital is touching the spinous process, is not touching the spinous process, so allowing the contrast to come in. Here the head is tilted, is more hyperextended, it's touching the spinous process here, so the contrast is stuck right at this joint here. Again, nice even flow right into the brain, causing headaches. This one, the contrast kind of stops here because it's more flexed. You can kind of see the lordotic arch right here compared to this one, which is kind of straighter. All right, again, what we're looking at here is H and P. So basically we see the contrast kind of coming in. So L3, L4, L5. Again, L3 is right here, and the contrast in the spinal canal. So again, keep trying to show you guys the pathology. H and P is the most common one. So there's like a little pimple right here. This is where basically you have the discs here. So the discs are like the cushions in your shoe, and basically it's coming out more, and it's basically pressing onto the spinal canal, causing pain to the person's back, also to the legs. It causes people to trip all the time. Again, I've had this issue and I had to do physical therapy for 3 months, so definitely not fun. Again, if you look here, this is the sacrum, this is L5, L4, L3. So the disc is coming here and is pressing onto the spinal cord right here. Basically what this says here is talking about the H and P. So here it's normal, here it's normal. All in this case, all of the discs are here. There is nothing leaking out, but then all of a sudden here, the disc or the jelly inside is popping, pressing out and pressing on the spinal cord here. So between the L4, L5 disc right here. Again, herniated disc is right here. Again, here's your normal disc, vertebral body. So normal, normal, normal all the way down, and then boom, a little pimple right here. Little small pimple, but extreme pain when it's pressing on the nerve. Another picture of the H and P. Now we have our axial images here and our AP images, and it's just kind of coming out here on this side on the right. All right, for our last slide is our post instructions. Immediately after procedure, patient will be monitored for 1 to 2 hours. Patient's head will be elevated 30 to 45 degrees during this recovery time. The patient should be on bed rest for 8 to 24 hours with the head slightly elevated. The patient should drink plenty of fluids. The patient should be instructed to notify a physician or medical staff if he or she experiences severe headaches or nausea and vomiting. So some slight headache could be normal, but if it's severe or if you have the nausea, vomiting, definitely call the physician or the medical staff. It could be the radiologist that did the procedure, or they could just call their own primary care physician as well. But most likely the primary care physician may refer you back to the radiologist. And that's it. Thank you guys.